Good evening. The brain and spine are vital to keep the body alive and functioning. Everything we do depends on the messages or the nerve impulses that are sent from the brain along the spinal cord and on to the rest of the body. To know more, we have with us today Dr. Chandrasekhar and Dr. Shankar Ganesh, neurosurgeons at Apollo Specialty Hospital, Tenampet. Good evening, doctor.
Good evening, ma'am.
What are the major brain conditions that we come across at Apollo Specialty Hospitals, Tenampet?
Starting off, possibly I'll start with that question. Commonly, if you see, it will depend on the age group, but without setting aside that, most common will be the head injuries. And along with that, you can have associated spinal cord injuries. And subsequently, here at Apollo Tenampet, because this is a known oncology center or a cancer center, we tend to see lots of brain tumors followed by spinal cord tumors. Apart from that, we also treat lots of spinal disorders like disc collapses, degenerative spine, or spinal injuries. And moving on from that, we have some vascular conditions called as blood clots within the brain for various variety of reasons. In brief, it could be either a ischemic stroke where the blood circulation could be blocked to a particular part of the brain, and that can cause a stroke, or you could have a blood clot in the brain causing a stroke. So these are the primary or major, this one what we come across on a regular basis.
And how are these brain lesions diagnosed, doctor?
The brain lesions are usually diagnosed with a CT scan. Once a patient presents to us with symptoms like headache, vomiting, or seizures, the first investigation of choice would be a CT scan. And if a lesion is diagnosed, we move on to MRI, and MRI would give us a better idea of the type of lesion. We plan our treatment based on MRI report.
And who would require a brain surgery or a spinal surgery?
As I just mentioned, it depends on the condition that what we are coming across. If, say, a patient is significantly injured, there's a large blood clot in the brain, or sometimes occasionally the brain tends to be very severely swollen up. You need to create space for the swelling brain. We tend to make a large opening, prying open the calvarial wall or the skull bone to give brain for the, give space for the swelling brain. Then patients who have got brain tumors, or if there's a large blood clot in the brain, and as I mentioned, like some of these ones could be caused for some other reasons like aneurysm, AVM, so they may need surgeries for this. As for the spinal cord goes, again, the surgeries could be for disc prolapses or some spinal instability or spinal tumors that we may come across.
My wife did an MRI and there is a compression and bulges in L4 and L5 disc of spine. And for the last 1 month, she has severe pain in her pelvic region and legs. So please tell me the perfect treatment for this. Is it okay to treat it by medicine or is surgery required?
Okay, I think I'll answer this question. This one, I'll put it a little differently. It all depends on what is the age of the patient, how long the symptoms are, symptoms have been or the complaints have been. Usually, if we take patients come with back pain, sudden onset or recent onset, and it's been just there for the last 2-3 days, we initially normally manage them conservatively. Not that every patient with back pain needs surgery. Almost 85 to 90%, the back pain tends to be because of or the majority of them will be because of something called a fibromyalgia or a common muscular strain. The next one, what we tend to come across in a younger age group is something called as this disc prolapses, which again is a distant second. Even if you have a disc prolapse, majority of this, as I mentioned, about 85 to 90% of these can be conservatively managed and overcome. Most of them won't require surgery. Then you've got a variety of other conditions which may require surgical intervention. So we don't need to really rush in for even an MRI to begin with. If it's a very short duration history, you treat them conservatively with some bed rest and some painkillers. They settle down, leave alone. Then we've got some red flags. They come with significance, say there is some weakness of one leg, they develop some urinary retention or some bladder disturbance, some other additional symptoms which seems quite relevant. Only those patients we tend to investigate early. Otherwise, a trial of conservative, then they don't clear that, they don't get better, you can always do an MRI. Unless, as I mentioned, we have some red flags.
Speaking of surgery, what is minimally invasive spine surgery?
Minimally invasive spine surgery, like what we have seen in other specialties of medicine, of the medical field, like laparoscopy in general surgery, then laryngoscopy, I mean, different types of scopies, what's being done in other specialties. Now, slowly, even in brain and spine, we have started making small openings and treating some specific pathological conditions through the small, minimally invasive openings. We don't tend to make big openings. But again, as of now, the possible ones which could be still treated that way is still a small number as far as the brain lesions go. And so is the situation for the spinal disorders also. But it's evolving. I think eventually, like all other subspecialties or rather other specialties, we expect ours also will become significantly minimally invasive over a period of time.
Is a brain CT scan sufficient enough to determine all types of brain tumor, or do I need to go ahead and do an MRI? I did a brain CT for scan of brain tumor, by the way.
Brain CT scan is only to diagnose a lesion or a tumor. It'll only give us a rough idea about the location of the tumor. In order to plan surgery and further treatment, we need to have more detail about the tumor, its location, whether it is stuck to some important blood vessel or nerves, and the way to approach it, and also to have an idea about the type of tumor. For all these more advanced specimen, we need MRI, because MRI is got much better resolution. It will give us a better idea. So to plan surgery, definitely MRI of the brain is required.
What would happen if a tumor is left untouched in a patient? What happens after the tumor takes over their life?
Tumors generally are of two types. One is benign and other is cancerous. Benign tumors tend to grow slowly, and obviously cancerous ones, they grow very fast. So it all depends on the type of tumor, whether it's benign or cancerous, and also on the location of the tumor inside the brain. If a tumor is located at a very critical area in the brain, for example, in the area controlling our limb movements, or in the speech area of the brain, or if it is involving the nerves controlling our swallowing, speech and all, patients tend to have symptoms much earlier. So all these factors have to be considered, like location, type, size. All these factors have to be put together to decide whether a patient would need immediate surgery or whether the patient can just wait and observe.
And if I can buttress on that, how I generally tend to talk to the layman about brain tumors are that, unlike other situations where like the tumor growing, you've got enough space for the area to keep expanding. Unlike that, in terms of, for brain tumors, the brain is contained in a closed space. So it's not going to be able to expand. Consequently, they are, apart from the tumor per se, they tend to produce symptoms of raised pressure, headache, vomiting, because there is no space for the additional component that's being added. So simple way to put it is like blowing a balloon. If you take a balloon, when you initially blow, you can really blow it quite quick. But then you come into the second phase where you could still blow, but you can blow it slowly. If you tend to blow it fast, it's going to burst. The third phase, of course, when the patient is, say, decompensating in terms of becoming unconscious, or sometimes some of them succumb, is where the balloon bursts. So I think this is the easiest way for the layman to understand.
Can stress cause tumors?
Stress is not directly related to tumors. It doesn't, but stroke can.
What condition can be treated with MISS?
This is what we just, we mentioned about earlier. MIS is nothing but minimally invasive spine surgery. It is spine surgery, minimally invasive spine surgery. It's still in its infancy and evolution, unlike minimally invasive procedures in other specialties. But still, yes, there are certain this one where it's quite elegant, and more importantly, we are able to get the patient out of the hospital the same day, if not maybe a day later. Common conditions that could possibly be treated, or one of the commonest is the disc prolapse, where you just make a small hole, access to the area where the disc is herniating, and through a small opening, you take it off. And lots of time now, we have started doing these things under the local anesthesia. Then the next one could be some patients with some degenerative spine, where you tend to take off some thickened tissue. Again, it can be done through this one. Rarely, there are certain centers that have started doing tumors, spinal tumors situated closer to the surface and towards one side, where we could even, again, through these procedures, you can access some particular situations where you are suspecting instability, and you could still put screws and rods to stabilize that area. Even this could be done through a minimally invasive spine procedure.
Hello, doctor. What is the role of radiotherapy if the tumor is cancerous?
Generally, the first line of treatment in brain tumors is surgery. We try to excise the tumor as much as possible in a safe manner. And irrespective of whether we have completely removed the tumor or when there's a small residue, most of the cancerous brain tumors need radiotherapy. So for all the small residues which have been left behind, this radiation will kill those cancer cells and keep them under control for a certain period of time.
I am male, 28 years old. Hello, doctor. What is the success rate of a lower back surgery? Is it possible to do hard work if the surgery is successful? I have been recommended to undergo the surgery by my doctor.
This is like a single key for all the locks. It doesn't work that way. It all depends on, as I mentioned initially, the commonest cause of back pain is something called as fibromyalgia or a muscular strain. Most of them will settle down with conservative treatment, like let's say some bed rest with some painkillers. Then, as I said, it's a disc prolapse again, which is again a distant second. There again, most of them can be treated conservatively. Only if they fail conservative, you're going to look at, though yes, there has been commercialization, no denial, but as I said, most of them can be treated conservatively. Only a small number will require surgical intervention. Then you've got certain other conditions like spinal instability, spinal tumor. So eventually, whatever your doctor has recommended, we should know what is the reason why he's recommended you for a back surgery. And also the age also has an impact on the kind of back surgery you may be undergoing.
Can you tell us a little bit more on fibromyalgia?
In a common man's term, it's nothing but a common muscular strain, a sudden abnormal change in posture, a jerky posture, or like when we are traveling, we have a sudden bump. We tend to develop some muscular pain or pain on the back on either sides. So something similar, that's what we commonly come across. Most of them will settle down with some bed rest and painkiller. So that's the alternative term what we commonly use.
I am 25-year-old female from Chennai, 5 feet 2 inches. I was diagnosed with scoliosis 3 years back, and doctors have suggested doing the spinal fusion surgery next month. My curve is at 40 degrees. Is surgery necessary, and will I be able to overcome it without the surgery? Are there any options?
From what you mentioned, considering your age and already having, they have already measured the angle and they have told you. Usually this is not really essential for a common man, the angle. So I think based on the calculations, they said you will need a surgery. I think probably they have suggested you the right modality. I think we should go ahead. Left alone, as the deformity keeps increasing and progressing, the other attendant problems, correcting it becomes difficult, and you could have other associated problems because of the deformity itself.
What is meant by spinal instability, doctor?
Spinal instability is like basically if you take the spinal bones, there are multiple units, each linked to the next one with something called as joints, which are primarily supported by ligamentous structures and soft tissue structures. Okay, so if there is either laxity of the ligaments, or as we get older, there's wear and tear. So when this happens, these tend to loosen up, and or there is an alteration in the balance or some extra bone growth, degenerative changes, which tends to weaken the joints. So these can produce, or sometimes because of an injury where there's a fracture, they could produce instability. So where one bone tends to move over the other, a constant movement of one bone over the other or one joint over the other tends to produce not only pain, you can also have increasing neurological deficit. So you will have to address both of them. You tend to fix that. So that is what essentially is meant by spinal instability.
My sister is suffering from meningioma, brain tumor, for the last 2.5 years. Surgery has already been performed twice, one time open surgery and one time GKRS surgery. Now there is a recurring tumor after the GKRS surgery also. Doctors are again asking to perform a surgery. Kindly advise.
Meningiomas are generally slow-growing benign tumors, and in most of situations, we'll be able to remove the tumor completely. But if the tumor is located in a very inaccessible location, or if it is involving major nerves in the brain or blood vessels, usually the surgeon leaves a small portion of the tumor and removes the rest of it. And these residual tumors can grow, and for which already this GKRS is gamma knife radiosurgery has been done. The GKRS is not actually a surgical procedure; it's a form of focused radiation. So this focused radiation is given to prevent further growth of the tumor. But if in spite of GKRS, if the tumor is growing, depending on the grade of the meningiomas, some meningiomas tend to recur more frequently than others. And if it is of that type, and if the tumor volume is also large enough, causing significant pressure effect on the brain, she would need another surgery to remove it completely or to debulk it as much as possible.
What specialists should
If I can answer, I mean, additionally add a little more to that, this one. Meningiomas, as Dr. Shankar Ganesh mentioned, these are benign tumors, but unfortunately, they also have some grades on that, grade 1, grade 2, grade 3. Grade 1 tends to be the most benign of the lot. Grade 2 and grade 3 tend to be a little more aggressive tumors. The fact that in 2.5 years' time, this patient has had already 2 surgeries followed by gamma knife, and despite that the tumor has again recurred, most likely it's a much more aggressive variety of the tumor. So going by what we have heard, irrespective of what you're going to be doing further, because now I'm very sure the gamma knife should have been given very recently. You may not be able to go back and give further radiation. So the option available here is probably go back, try to remove as much as tumor as possible. This possibly could add quality to the patient's life rather than trying to look at a cure in this patient.
Thank you, doctor. What specialist should one consult if he or she has a back pain?
A neurosurgeon would be the best specialist to consult for back pain. See, generally, when a patient comes with a back pain, we have to assess him clinically to check whether all his nerves are normal, take a detailed history, and find out what is the reason for his pain. Back pain could originate from various tissues like muscle, bone, joints, ligaments, or from the nerves. So, reasonable diagnosis should be made clinically. And depending on the clinician's advice, if MRI is advised, the MRI could show some small disc bulges. These disc bulges are very common these days. Many people with sedentary lifestyle do have a lot of disc bulges. So just going by MRI finding, a treatment should not be planned. There should be a clinical radiology correlation where a clinician sees the patient's condition, history, examination, and correlates it to the MRI finding, and the final treatment plan should be drafted. So a neurosurgeon is the best person whom we should consult for back pain.
So in other words, what Dr. Shankar is trying to also convey is that most of the time, orthopedicians' decisions are based on what they are looking at the images. Once they see something on the MRI, they straight away said you need, or rather they straight away say you need surgery. So that has its own problems. One thing is, I'm sure after a certain age, something like doing an ECG for the heart, you are going to find some changes after a point of time. Same thing with the spine. After you reach a certain age, you are going to, or like somebody does an abdominal ultrasound, they'll say you've got gallstones or a kidney stone. Gallstones, especially, not that all of them possibly will require an intervention. Same thing here with the back pain. Just because you see something on the MRI, it doesn't mean you need a surgery. But unfortunately, lots of time now with orthopedicians being so aggressive, they see something on the MRI, they straight away recommend that patient needs surgery. Unfortunately, their clinical evaluation is not going to be as complete as what a neurosurgeon can offer. So it is more of a clinical decision in combination with what we see on the MRI. So I would rather fully agree with what Akshankar says, that this should be possibly primarily be handled by the neurosurgeons, unless the orthopedician has had a formal spinal training in centers doing lots of spinal work.
Does L4, L5 disc protrusion lead to sciatica? And what is the basic treatment for sciatica, doctor?
This is what, as I again initially mentioned, L4-5 or L5-S1, these are the two commonest levels where we come across disc prolapses. See, either they can produce pure back pain, which is called as a lumbago, or they could have pain from the back radiating all the way down into the legs. That's what is called as sciatica. That's because the particular nerve root which presses the disc, that the herniating disc presses on the nerve, stretches the nerve and produces a pain, which goes down all the way up to either the toe or the little fingers. Every sciatica, as I already mentioned, doesn't need surgery, or rather every disc prolapse doesn't need a surgery. Almost 85 to 90% can be conservatively managed. Unfortunately, in today's commercialized world, most of them, the moment somebody comes to you with a back pain, they want to investigate. You see something on the MRI, as I just mentioned, what could possibly be the reason, and you jump on to operate on these patients. It's only that 10 or rather 10 to 15% who don't benefit conservative, or they will come with some specific red flag where they got a urinary retention, or the pain is so severe they are not able to bear it, or a young athlete who has had a significant onset of pain, acute. We know that yes, you could have a sizable disc prolapse. So these are the patients where you can think of intervening early. Otherwise, you don't even need to jump into doing an MRI. Wait, put the patient on a conservative trial, say for about 3 to 5 days with some painkillers. He settles down, leave him alone. Otherwise, go ahead, investigate, and look at surgery as an option.
I'm 28-year-old male. I have backache for the last 2 months. What should I do? In 2006, I got a surgery and anesthesia was given in my spinal cord. Does it have a correlation?
Back pain is like what Dr. Chandrasekhar said. It could be of various reasons. The commonest one being fibromyalgia. You would have had a strained back because of his posture or lifestyle, and the history is very short. So you should consult a doctor and probably take only painkillers and muscle relaxant. And if the pain is not settling down, probably you should review with the doctor, who might advise MRI. And generally, the spinal anesthesia is given using a very fine needle, and it will not produce persistent pain for for more than 5 days. So the anesthesia which was given in 2006 cannot possibly have any side effects right now.
I'm 33-year-old male from Bangalore working in the IT industry. After my spinal surgery 2 months back, I am feeling a tingling in my left arm. I had inquired with my doctor and he said spinal surgery has nothing to do with the left hand tingling. Now the tingling has gone, but I feel a lot of numbness and sometimes weakness. Kindly advise.
I think what you mentioned to you was right. I mean, the spinal surgery, what you underwent is something in the low back area. That should not have any relation to what you have experienced subsequently. So your spinal surgery, I assume, probably considering your age, you would have had a surgery for a herniated disc. So you could have a similar herniated disc in the cervical area, which could be producing some pressure on some particular nerve root. Maybe you will require an evaluation further. If your doctor asked you for an MRI, please go ahead, get an MRI done, evaluate. If there is any suggestion of significant nerve compression, you would require decompression for the same.
What are the lifestyle habits that needs to be adapted or changed post a brain or a spine surgery?
Post spine surgery, I mean, the treatment of spine surgery doesn't end with surgery. A post-operative rehabilitation is very important. I would rather say it's equally important as the surgery itself. So after once surgery is over, the doctor would have removed the offending disc or the tightness of the canal, but the patient has to build up his back muscle, strengthen it suitably so that the body weight is borne equally by the muscle and the bone. Healthy lifestyle in the form of brisk walking, daily jogging, maintaining ideal body weight, and the way the person walks and sits. All these things are important. Like people working in IT industry, they tend to sit for long hours. So they should have good office ergonomics where the chairs are comfortable with good lumbar support, and the way they use their car and two-wheelers, and even the way they sleep. There's multiple videos and things available in Google and YouTube where they explain what is the ideal position to sit in the office and even at bedtime. And as far as rehabilitation after brain surgery is concerned, it's too vast. It depends on the type of tumor and the location and the a type of surgery or treatment offered.
My wife, 62-year-old, underwent a spinal cord surgery 2 years back. And while surgery, the doctors had used a little overdose of local anesthesia because it was required. But now she's suffering from neck pain. Does it have any correlation? Is it related to each other?
I mean, from what probably she's had, I mean, considering her age, she should have had surgery for something called as a degenerative spine. It's called as a lumbar spondylosis. So we also call it as a degenerative lumbar canal stenosis. Most likely that could have been the reason for that. Or the other thing could be a osteoporotic spine. Considering the age and considering the sex, it could be an osteoporotic spine. So primarily we need to know what was the primary diagnosis. If it was a degenerative spine like what you had in the back, you can have in the neck also. So I don't think there was any correlation to your neck and your back, whatever you're experiencing now. Again, as we just mentioned earlier, probably you'll need further evaluation for that. And if it also shows significant degenerative changes, I mean, at the level of the neck, that needs to be addressed.
Does cyberknife play an important role if the brain lesion is cancerous?
Yeah, cyberknife is a form of radiotherapy. So, like I mentioned earlier, the first line of treatment is always surgery. Only in selected cases where surgery is not possible, or if there's a small residual tumor which is present after surgery, the patient would require radiation. And for selected type of even benign tumors in certain locations, upfront cyberknife treatment can be given.
Like as you mentioned earlier, cyberknife, gamma knife, they're all similar. Then now like Apollo, I mean, these are all already, they're all advanced tools in management of brain tumors and some tumors elsewhere in the body. Then Apollo also has added something called as a proton newly. Again, these are nothing but giving highly focused radiation at a much higher dose, primarily to the area of the tumor or the tumor bed. You tend to kill the tumor cells, preventing any damage to the surrounding normal tissues. I mean, they come with a little bit of cost, but yes, the benefit out of them could be significant, but you go by strict indications as to what could be treated by cyberknife, gamma knife, or proton.
And can surgeries be avoided using these modalities, doctor?
Very unlikely that you can do, I mean, especially definitely not for cancerous tumors, because first of all, you need to have a diagnosis. What could be the type of cancer? Or if you already have established a diagnosis of cancer elsewhere in the body which has spread, If it is in one particular area, maybe you can look at, but otherwise most of the time you need a diagnosis. But essentially, unlike other places in the body, here the diagnosis doesn't end with just a biopsy. Most often when we tend to look at a biopsy, we tend to take away as much as tumor as possible, if at least not possible to remove completely, because it helps to make the radiotherapy more effective. So there are certain specific conditions like acoustic neuroma, where we know that the tumor is small, say about less than 3 centimeters in diameter, and we are absolutely sure that it is a tumor which could be treated only with the CyberKnife or gamma knife. Those are the tumors which we could look at, but that's going to be a very limited indication. Has to be done in consultation with the neurosurgeon and the radiation oncologist.
What is the best treatment for brain aneurysm?
Brain aneurysm depends on the location. Most of the aneurysm which are present in the front part of the brain, which is called as anterior circulation, most of them are amenable for surgery. So surgery would be a better choice. For aneurysms which are too large, or if it's a very complex anatomy, or the ones which are occurring at the backside of the head, then the recommended form of treatment will be endovascular treatment. In the sense, through an angiogram, these aneurysms can be blocked with coils, and float inside the aneurysms can be blocked.
Thank you, doctor. What is your message for our viewers today?
Brain tumors, whether it's benign or cancerous, are treatable. And even those with the cancerous brain tumors can have good quality of life if they undergo proper treatment and if they are diagnosed and treated at a good center. And wear a helmet. Helmet saves head injury. Helmet saves your brain. So don't drive two-wheelers without helmet.
And mine would be something similar. Thanks for listening. Again, it depends on what is the condition we are looking at. Most importantly, like for if you're looking at spinal conditions, please don't self-medicate. Same way for some headaches, which has been for some period of time, don't self-medicate. If you think there has been no relief in a day or two, please visit your doctor, consult with him. If he thinks it's benign, please go ahead. Otherwise, you will need further evaluation. As far as the head injuries go, yes, compulsorily, please use a helmet, which definitely makes a significant difference, one in terms of saving lives and also reducing the severity of injury. Thank you.
Thank you very much for an informative session, doctors. For appointments with Doctors Chandrasekhar and Doctors Shankar Ganesh at Apollo Specialty Hospital, Tinampet, please contact 044 611 51111 and 044 611 51295. I repeat, 044 611 51111 or 044 611 51295. Thank you very much.
Thank you.
Thank you.